The patient is a 35-year-old dental assistant with missing side teeth, which is of an aesthetic concern, and she would like to improve her function and replace the missing teeth with something fixed. She has had childhood asthma, but otherwise a clear medical history. Extraorally, she has a brachiocephalic profile with adequate and no abnormal range of movements. There's no abnormalities or discrepancies in her temporomandibular joint and has a stable occlusion. The 1, 4, and 2, 3 were extracted many years ago and has had multiple restorations. During the time of examination, some active caries lesions were detected on the 2, 4, 2, 5, and 1, 5 is non-vital. The teeth were restored and the 1, 5 has been root treated then. The patient has a good oral hygiene. Her oral hygiene was poor in her youth 10 years ago before joining as a dental assistant. Currently, the basic periodontal examination has a score of 1. She plays harmonica as a hobby and is currently wearing an upper acrylic removable partial denture and does not enjoy wearing it. The diagnosis pertaining to this case would involve a partially dentate upper arch with missing 1, 4, and 2, 3. Interproximal caries lesions were present and 2, 5 was non-vital. Discussions of treatment options would include no treatment, extraction of 2, 4, followed by a reline of the removable partial denture with new dental tooth, dental implants replacing the 1, 4, and 2, 3, 2-unit bridges to replace missing tooth 1, 4, and 2, 3 using the adjacent teeth as abutments, and dental implants replacing the 1, 4, and 2, 3 followed by a resin bonded bridge as a provisional restoration during the healing process. Of course, the last treatment option was chosen as the comprehensive treatment plan. The definitive treatment plan would then involve first caries control and oral hygiene instructions, endodontic treatment of the 2, 5 followed by core, and dental implant treatment replacing 1, 4, and 2, 3. As the implants were placed in enclosed and sutured by primary closure, they are allowed to osseointegrate for a minimum period of 3 to 4 months. And during that time, instead of tolerating the current removable partial denture, we decided to fabricate Maryland resin bonded bridges. This is used as a conservative fixed transitional prosthesis while waiting for the full osseointegration of the implants to be completed. A resin bonded bridge consists of a cast metal framework that is cemented with resin composites to an abutment or abutments, which preparation is confined either entirely or almost entirely to enamel. The resin bonded bridge is a good treatment option for many missing teeth as it is relatively cheap when compared to alternatives such as dental implants. It requires little or no damage to the surrounding teeth during preparation for placement and is well tolerated by patients. Typical success rates have been quoted as being as high as 80% after 15 years in the anterior maxilla. One major advantage of the resin bonded bridge over a conventional bridge is the failure mode, which is likely to be debonding of the retainer. In conventional bridges, failure mode would likely be complete fracture of the abutment tooth and other forms of catastrophic consequences, which may require extraction of the abutment tooth or elective root canal treatment. With a resin retained bridge, the prosthesis can usually be cleaned off and debonded in position with minimal inconvenience to the patient. A very specific set design of principles is implemented for resin-bonded bridges. The wing or retainer must be rigid and is usually fabricated from a metal alloy. The inner surface must fit closely to the abutment tooth. The intaglio is treated in some way. In this case, modern resin retaining wing is usually sandblasted with an alumina powder, and the surface is roughened. The pontic is usually made from dental porcelain, where the whole restoration is thus actually a porcelain fused to metal restoration. Cements that are commonly used will include resin cements. They are either auto-cure or dual-cure to ensure complete polymerization of the resin under the wing. Great care must be taken during cementation to avoid contamination of the operative field, as this will lower bond strength of the cement and lead to premature failure. For this reason, rubber dam is often advocated for placement. However, in this case, this was not possible as cementation could only be performed post-operative after the implant surgery. Outcome of the case. 1 week after the procedure, the bridges of both sides debonded as moisture control was a challenge during the cementation right after the surgery. We took the opportunity to remove the sutures, and the bridges were cleaned and re-cemented. Bite and occlusion were checked and adjusted. They were then polished at the metal wing level to provide a smooth surface. No other adverse incidences were observed until 4 months after osseointegration. The resin-bonded bridges were removed without any problems. During the treatment, the patient has expressed improved comfort and increased sensation of taste and temperature in her foods, and was able to play her harmonica with much more confidence.